In this section, I will go over upfront radiation as primary treatment for newly diagnosed prostate cancer. Again, if you're skipping forward to this part, the QR code at the bottom will take you to our website with a lot of updated information. So radiation therapy is the use of high energy photons, typically X-rays or other types of radiation therapy, to destroy cancer cells without actually removing them. Radiation can be given either from the outside in using external beam radiation therapy, or EBRT, or from inside out using brachytherapy, which are temporary or permanent seeds. Sometimes these two forms are combined, and in some cases we also add hormonal therapy, androgen deprivation therapy. This is treatment to drop the body's testosterone level down to a very low level, which improves the effectiveness of the radiation and the likelihood that it will cure the cancer. The most common type of external beam radiation therapy in the US is intensity modulated radiation therapy, or IMRT, in which radiation is given from beams applied at a variety of different angles and in various strengths to really try to get a high dose to the prostate while minimizing damage to surrounding structures. Usually before starting this, we put 3 gold markers or beacons into the prostate to help target the external beam radiation. IMRT is usually given 5 days a week for a short period of time each day, and this is repeated somewhere between 4 and 8 weeks, with the trend definitely being towards shorter courses of treatment, what we call hypofractionation. Brachytherapy, on the other hand, is given using radioactive seeds, which either we place permanently into the prostate, or a version called HDR, high dose rate brachytherapy, passes a very hot radioactive seed in and out through catheters, which are placed temporarily inside the prostate. Brachytherapy requires at least a spinal anesthetic, or in some cases a general. Either is performed as an outpatient procedure, or sometimes with a one-night stay in the hospital, depending on the details of the treatment. And the two are often combined, where brachytherapy gives a high dose to the prostate called a boost, and then external beam radiation is used to treat the prostate as well as the rest of the pelvis, to treat any microscopic disease in the lymph nodes as well. Increasing in use and popularity is a version of external beam treatment called stereotactic body radiation therapy. There are several versions of this. The most common one is called CyberKnife, and this gives the radiation even more precisely and in a more customized dose distribution than IMRT, which allows it to be done over a short number of treatments, typically only about 5. This is meant to give a brachytherapy-like dose distribution to the prostate, although few studies have actually compared those two directly head-to-head. You will definitely hear about proton beam radiation therapy if you spend enough time surfing and looking in the internet about prostate cancer treatments. Proton therapy is another form of radiation therapy. You will often see it compared to radiation. Proton therapy is radiation therapy. Instead of using X-rays or photons, it's using protons. It's aggressively marketed by certain centers in California and elsewhere because it's compensated extremely well from Medicare and other payers. But the reality is, even though there's all kinds of marketing about no exit doses and pretty pictures, and there's lots of patient testimonials, there has never been a single published paper anywhere ever showing any clinical benefit for proton therapy over other forms of radiation therapy in terms of cancer cure rates or avoidance of side effects. So proton therapy is not a bad way to treat prostate cancer, but it's absolutely no better than any of the other forms of radiation we've been talking about in any way. Now, radiation does not instantly destroy the cancer cells. Rather, it damages the DNA to the point where the cells cannot divide, and ultimately to the point where they cannot survive. But this is a slow process, so the cells will die off slowly, and the PSA will fall more slowly than it will after surgery. It can take up to 2 years for the PSA to reach its low point, or its nadir, after radiation therapy. In fact, we will often see the PSA bounce up for a short period of time, especially after brachytherapy, and then start falling again. Now, if it really does start rising steadily after radiation, typically we will repeat a biopsy to see if there's any cancer left in the prostate. And if there is, we can talk about salvage treatment, either additional radiation therapy, sometimes cryo, or other forms of ablative therapy or surgery, although the risks of any of these things is higher than the risks would be upfront. Now, for lower risk cancers, not the low risk cancers, which really should be managed with active surveillance, but the ones that are in the better end of the intermediate risk range, cure rates are probably quite comparable between surgery and radiation therapy. For higher risk cancers, this is controversial. Some studies suggest that surgery, often combined with radiation therapy, yields better cure rates than radiation therapy alone. But again, this is a little bit controversial and depends on what you read. And this is definitely a topic that you should talk about in consultation when we really look at the details of your specific cancer. Now, the side effects of radiation therapy are different from those of surgery. We really try to avoid thinking in terms of one being better or safer than the other. The risks are different. So radiation is less likely than surgery to cause urinary incontinence or leakage, and it has less of an initial impact on sexual function. However, no matter how perfectly the radiation is given, there's no getting around the fact that the urethra goes right through the middle of the prostate, the bladder is right next door, and the rectum sits right behind the prostate. So some dose always gets to those organs, and radiation typically will produce irritation symptoms, at least in the short term. So that's symptoms like having to go to the bathroom more often to urinate or have a bowel movement or both. You can see some blood in the urine or the stool, diarrhea, and general fatigue, feeling tired. These things are all common for the first couple of months. They usually get better with time, but there are low long-term risk after radiation therapy, just like there are with surgery. We can see things like stricture, which is scar tissue forming in the urethra. They can block the stream, make it difficult to pee. Very rarely we can see fistulas, which are holes opening between the rectum and the urinary tract that can cause chronic infections. These can be difficult to manage if they happen because the radiated tissue never quite recovers back to what it was like before. We can also see a decline in sexual function over the longer term after radiation therapy. By the time we get to 3 or 4 years out from treatment, there's less and less difference between sexual function after nerve-sparing prostatectomy and after radiation therapy. There's also a slight increase in the risk of rectal and bladder cancer if we think forward at least 10 years after prostate radiation. Now, those are still rare cancers, so we think about the risk roughly doubling from very rare to still quite rare. However, I would say that we take seriously symptoms like blood in the urine, hematuria, particularly among smokers, after radiation therapy, because this can be a sign of bladder cancer. Finally, a brief note on hormonal therapy, on androgen deprivation therapy. Men with higher risk cancers who are heading down the radiation path will typically get hormonal therapy for somewhere between 6 and 24 months. This is treatment to drop the testosterone level down to a very low level. Without testosterone, the cancer cells will shrink, they regress, and this improves the likelihood of response to radiation therapy. Hormonal therapy should almost never be used by itself for non-metastatic prostate cancer. It's really just used as an adjunct to improve the outcomes from radiation therapy, unless the cancer is spread to other parts of the body, which is a very different conversation. Now, hormonal therapy does have its own set of side effects, which are additive with those that we see with radiation or other forms of treatment. These include hot flashes, feelings of heat and flushing, sometimes sweating, fatigue, drop in libido, and sex drive, and sometimes changes in mood or concentration or memory. Longer term, hormonal therapy can raise cholesterol levels and blood sugar, and it can weaken the muscles and the bones, and can increase other cardiac risk factors as well. It is extremely important to be exercising aggressively while on hormonal therapy. Both cardiac exercise and weight bearing are both important to keep the body strong.